so that you can improve your day-to-day endoscopic practice, as well as training your trainees. So the objective of today is to briefly talk about pathology, the types of lesions, the classifications, and how it may apply to our practice in future. So we know that colonoscopy saves lives. Polypectomy has been shown to reduce mortality by over 50% from colorectal cancer over the course of 10 years or more, in the absence of deeper invasion. And this is because colorectal cancer is a preventable disease. Most cancers occur via the adenoma to carcinoma sequence. Polyps begin from normal mucosa and develop dysplasia through a series of genetic mutations. They stack up, leading up to carcinoma. If they are found in time, they can be resected. Other pathways include the serrated pathway and alternative pathways where traditional serrated adenomas form. But generally, we have a situation where polyp tissue have contained dysplasia, and they get progressively more dysplastic over time, going from low-grade to high-grade dysplasia and then turning into cancer. And there are opportunities for intervention during this stage. The median time from a small polyp with low-grade dysplasia turning cancerous is probably around 20 years. Larger ones may take 5 to 7 years, and this is known as the polyp dwell time. So going back to the polyp types, this is how they look endoscopically. So on the left here, you have a low-grade dysplastic adenoma turning high-grade dysplasia, and then into carcinoma. And on the right, you have a hyperplastic polyp, and then at the bottom, there is a sessile serrated lesion. And in the middle here, you have a TSA, which is a rarer type. So why classify polyps? Because we need to know what we're looking at. The eye can only see what your brain recognizes. The first thing you do when you see a polyp is think, is it normal? Is it a hyperplastic polyp that can be left in, or do I need to do something about it? Does it need resection? And then thirdly, is it actually resectable? Because if it's too invasive or too large, it may not be something that you want to tackle straight away. The SMIC stands for submucosal invasive cancer. Some of it you can see on the surface, but some of it you can't see it. And this is called occult SMIC, and I'll talk a bit about it later on. How do we manage it when you see a lesion? Is it something that you take off with cold snare, EMR, ESD, more advanced techniques? Or is it something that you biopsy, you tattoo, and send for surgery? If you biopsy an adenoma instead of resecting it, that can cause problems with submucosal fibrosis and cause problems with incomplete resection. So it's important to recognize it and get the management right. What is the chance of complications with the polyps? And what do I tell the patient or my colleagues who I might refer complex ESDs to? So the classification is also important for documentation and communication. The Paris classification is the first step when we want to classify polyps based on morphology. And morphology means how they look, whether they're raised, whether they have a stalk, or whether they're flat. So most of you will be familiar with this. Tiny polyps, which are about 2 or 3 millimeters, are almost certainly going to be a Paris 2A because these are usually less than 2.5 millimeters in height to be considered as a 2A. If it's more than 2.5 millimeters and it's sessile, then it's a 1S lesion. This is important because flat lesions tend to carry a higher risk of SMIC, the invasive carcinoma. So depressed lesions have a 50% likelihood of harboring cancer, and these would not be endoscopically resectable. And these are examples of the Harris classification. So you can see that this one on the top left is 1S, and then you have optical diagnosis with virtual endoscopy, just giving it a different appearance. And then you have 2A in the middle, which are flat. And then the depressed ones, which really are cause for concern, are the 2Cs. The next is, how does the lesion look on the surface? Can it give us clues about what they actually contain histologically? Because the gold standard of looking at a polyp is to predict histology. Adenomas can be villous or tubular, or a bit of both, tubular villous. And then they can have either low-grade or high-grade dysplasia, or they can be cancer, or there might not be an adenoma. And the pit pattern classification that Kudo devised came from about 25 years ago, involving dye spray chromoendoscopy and zoom magnification. And we use this day-to-day for every lesion routinely in the UK now. So the most of the time, these lesions are 3 to 4, and then the 5 are the ones that we worry about. The next thing we do is use optical enhancement to really bring out the contrast. You can look at the color of the lesion, the vessels, and the pattern on the surface, and putting all that together, and with training and experience, that can allow you to predict the histology of lesions with greater certainty. Not to be outdone, because NICE is mainly for NBI, which is an Olympus technology, the simple classification was devised in Birmingham using eye scan technology. And this also relies on 3 factors. What does it look like on the surface? What do the vessels look like? Because with more dysplasia, the vessels look less and less regular, and they look dysmorphic. And then what do the borders look like? And all these allow you to be put together to form an algorithm so that you can predict histology. And actually, people can do well with training. Training platforms can allow one to improve the sensitivity of histological prediction, as well as improving negative predictive values, which are important for the resect and discard strategy that you may have heard of, that may save a lot of money by avoiding sending specimens to histology and discarding them straight away if you're confident with predicting histology. And then also accuracy of the histological prediction. And not to be outdone, Fuji, the third major platform, also have an optical diagnosis platform called BLI, and they have a basic classification system, which also looks at surface, the pits, and vessels. The JNET classification is very helpful in differentiating between high-grade dysplasia and deeper submucosal invasion. High-grade dysplasia may be amenable to things like ESD, whereas deeper invasion and the features that you see here would be something that we would send for surgery. And why do we do this? Because it affects management. And to a degree, not everyone will be 100% confident with what they see on the screen. And this is a nice algorithm here that incorporates what you think you see and how confident you are in interpreting the image to decide what to do next. So if you think that you are seeing a deeply invasive cancer that's a JNET 3, you would send it for resection. You would send it to a multidisciplinary meeting and resection. But if you're not so sure, then you can put a bit of dye spray chromoendoscopy and look at it more. So this is how it's helpful. Moving on to sessile serrated lesions, I want to bring up the WASP classification, which is very simple. And this looks at the 4 features that we see in SSLs. And these are predominantly in the proximal or right colon. And these are the ones that we have really got more of a handle on over the last 20 years. And before that, they were rarely diagnosed. People thought they were just hyperplastic polyps. And then we realized that these little lesions with mucus caps overlying them actually cause cancer. And now we are taking more attention to SSLs and even benchmarking SSLs. So SSL detection rates are now a benchmark, or becoming a benchmark in colonoscopy. So the features of SSLs include clouded surface, a slightly indistinct border, an irregular shape, and having dark spots within the crypt. I think that actually having a mucus cap is also a really, really good indicator of SSL. I just want to bring out the Sarno classification because that was devised by the JNet team, and they modified the Sarno classification, which was originally to do with vessel architecture, and they included 2O classification to include a system for differentiating SSLs. And the SSL criteria are cloud-like surface, irregular margins, a mucus cap, which is different compared to the WASP classification, irregular shape, and varicose microvascular vessels. These are more commonly used in Japan and possibly by some ESDists. Because you have been talking about IBD, we should touch on the CNIT classification of IBD-associated polyps. And these are seen, this basically involves the Paris classification that has been modified to comment on 2 things: the presence or absence of ulceration and what the borders look like. This is a seminal paper from Michael Bork's group in Australia that talks about occult SMIC. What is the risk of cancer when you don't see cancer? And the key things here are that distal lesions, so the ones in the rectum, are really tiger country. So this is the classification system for lateral spreading tumors, or LSTs. And LSTs are basically sessile polyps that are over 10 millimeters. And the non-granular ones, so you have granular and non-granular. The granular ones basically look like bubble wrap. And then the non-granular ones don't, they look a bit flatter. And the non-granular ones carry a higher risk of cancer, even though the surface pit pattern might be reassuring. They may look tubulovillous, but deep down, there's a risk of cancer. And the highest risk are the ones that are 1S or with a 1S component, where the risk of cancer occultly is anywhere between 1 in 6 or 1 in 5 or more, depending on the size. You can also guess the risk of occult cancer by not just from the LST morphology, but by their size. So this is a nice little study by Ishikagi last year in GIE. So that a 50 millimeter tumor, LSTNG, carries anywhere between 20 to 40% risk of cancer in there. So you have to be very careful before you attempt an EMR for such big lesions, and patients need to be consented properly. But what about predicting complications? The SMSA score stands for the size. So that's in centimeters. You have points for size. You have morphology. So flatter ones carry a higher degree of difficulty than those with a stalk, which is self-explanatory. So same with the ones in the right colon, and same with the ones that have difficult access, those, for instance, on a fold that is difficult to reach, on the diverticular bend, for instance. And you have a scoring system where SMSA4 carries the highest degree of difficulty. And this has been validated and has been shown to correlate with procedure time, the likelihood of completeness of resection, the risk of clinically significant post-endoscopic bleeding, as well as recurrence rate. And the recurrence rate of SMSA4 was about 1 in 4. And this was, I think this probably led to things like snare tip ablation of polyp margins after piecemeal EMR. And the recurrence rate for that now is a lot less. What does the future hold for us? Well, AI is getting everywhere. And it's been shown that AI not only improves polyp detection, as shown in this meta-analysis of superstars, who some of them may have spoken at your conference already, but also there's a role in characterizing. So this platform can characterize between nice type 1 and nice type 2 or type 3 lesions, and it even gives you a probability. There has been some progress with endocytoscopy, but endocytoscopy involves basically a microscope at the end of a scope that looks at tissue and polyps in real time. But through costs and things and AI, that has become a little bit less out of vogue. But these have also been bundled with AI systems to really confidently predict histology. So in summary, there are a lot of classifications out there. The ones that I use include morphology, what do they look like? And I use the Paris classification. What does the pit pattern and surface look like? And Kudo is good for that. What does it look like on optical diagnosis? I use NICE if I have an Olympus scope. Otherwise, I use other systems. If it's got high-grade dysplasia, if it's got a Kudo 5 pattern, I describe it using JNet. Is it a 2B or is it the 3? And that will differentiate the level of high-grade dysplasia or SMIC risk. And for sessile serrated lesions, the WASP classification comes in handy. And if you're not going to take out a polyp, think about scoring the polyp using the SMSA classification so that people can allocate the right staff and the right time slot for these lesions. Thank you so much for the invitation, and I hope that's been helpful.